Welcome to the virtual Infectious Disease Congress sponsored by Johns Hopkins University School of Medicine and ID Care Live. My name is John Bartlett, and you are tuned to the CME session called Game Changers in Vaccines. Dr. Neil Halsey is going to give the presentation. He's professor in the Division of Pediatric Infectious Disease, as well as professor of International Health, Disease Prevention and Control at Johns Hopkins Bloomberg School of Public Health. Before I get started, I'd like to remind you that we will be taking questions in real time throughout the presentation. You can send us your question anytime during the program, though the box on the lower left hand of your screen. I'll turn the program now over to Dr. Halsey.
Thank you. Thank you very much, John. I'm pleased to be here and to share some thoughts about game changers in infectious disease. And as I'm sure you understand, vaccines have been one of the biggest game changers that have affected the practice of medicine, pediatrics, and infectious disease in particular. Let me start with a few comments about pneumococcal disease and the enormous burden that this organism causes in the United States. In 2004, it was estimated there were over 4 million illness episodes, 22,000 deaths, 445,000 hospitalizations, and a number of emergency room visits. This is infections of all types: pneumonia, otitis media, meningitis, septic arthritis, and so forth. The Centers for Disease Control and Prevention maintains a program to monitor invasive disease. These are just the bacteremias, the meningitis, where you can get the organism out of a normally sterile body fluid. And as you can see, and most people are well aware, the introduction of the conjugate pneumococcal vaccine, the PCV7, was a major game changer for the practice of pediatrics and a dramatic reduction in the incidence of disease caused by the 7 types that were in the vaccine. They caused 60 to 85% of the disease in different parts of the country. And as shown in the red line, those types have virtually disappeared from pediatric practice. Small increase in a few of the other types shown by the green and blue lines. We'll come back to those in a minute. But in addition, the enormous benefit of vaccinating children against these types was the relative disappearance of those same strains of the 7 types that are in the vaccine in all adults over 18 years of age. These strains have now virtually disappeared from the radar screen and the ability to detect them from invasive pneumococcal disease. We don't know for certain about those that aren't invasive because we don't normally get cultures from those, but we believe the same is there. On the other hand, we had some increases, especially in serotype 19A, which progressively increased with the replacement phenomenon taking place. And there was concern that this replacement might be sufficient to minimize the impact of that vaccine. So the manufacturer increased the number of types of vaccine to make a PCV13, adding 6 types. And Matt Moore, who is at CDC and coordinating a lot of this effort, was kind enough to share these data with me. For children under 2, there was a gradual progressive increase, and it's seasonal, as you can see by the fluctuations in the line there. And projecting from the time when the 13-valent vaccine was introduced, they had projected there would continue to be some increases, but look at what happened. The actual data are in the black line down below. We've seen a disappearance of the 5 types out of the 6 that were added to the 13-valent vaccine. The other type we just don't see much disease from, so they've carefully monitored those. So the difference between the projected and what was observed are the averted cases, a rapid impact of adding these types. In addition, we see that the decrease was already evident by 2010 in people over 65 years of age of those types that were added. The 6 additional types are in the red line there, and there already was a decrease by the end of 2010. Matt Moore was kind enough to share with me these data that he presented just last month at the Infectious Disease Society of America meetings, looking at the impact of those additional types, again focusing on the 5 that really did cause a lot of disease. The first column here that's highlighted looks about the overall decrease in these 5 types by age group, a 55% in the children under 2, 60% 2 to 4, and so forth in all age groups. That's the overall reduction in pneumococcal disease, a major impact. And now you see the reduction in the 5 types and a focus on the 19A here, almost a 90% reduction in children under 2, but a 68% reduction in 18 to 49-year-olds and 54% reduction in under 65. A rapid impact from the introduction of this vaccine in all age groups. And so the impact is much greater than we get just from vaccinating children. You see a dramatic reduction with the indirect or herd effect because of reduction in nasopharyngeal carriage associated with this vaccine. 75% of the averted cases were in the adult population. So huge benefits from the adults by children being vaccinated. Works better than the plain polysaccharide vaccine, I would say. To bring to your attention some changes that haven't been implemented very well, but back in 2008, the ACIP recommended that the pneumococcal polysaccharide vaccine should be given to all adults who smoke or who have asthma, but the coverage rate has been miserable. We're only in the 20% or so range for those groups. So a lot of people are not getting this vaccine who should be getting it, and that's the 23-valent. In October of 2010, they clarified the issue of second doses. People who received the vaccine in 19 to 64 years of age should get a second dose after 5 years, but no further boosters. Those people who are over 65, and if they were vaccinated at least 5 years previously and were less than 65, they should get a second dose of vaccine. So no third dose yet, but a second dose is indicated for all of these individuals. The 13-valent vaccine has now been licensed for use in adults, and you will probably see some promotional materials with regard to its use. The question arose as to whether we should switch from the 23-valent to the 13-valent for routine immunization. The data that CDC has shows that 21% of the infections that do occur would not be prevented by the 13-valent vaccine. 50% would be prevented, but 23% would not. The other 29% are other types that aren't in either vaccine. So the recommendation is that for adults over 19 years of age who have immunocompromising conditions, functional or asplenic anemia, and CSF leaks or cochlear implants, those individuals should get the 13-valent first, followed by a dose of the 23-valent at least 8 weeks later. And we do it in this order because doing it in the other order, the reverse order, doesn't work as well. There is a blunting effect by giving the 23-valent first as compared to the 13-valent first. A second dose of the 23-valent vaccine is recommended 5 years after the first dose. So this group of individuals with selective underlying conditions gets 3 doses of pneumococcal vaccine, 1 13-valent and 2 23-valent in their lifetime. Let me add a few things to the discussion by Ruth Karen in the previous session about influenza and some things that will be game changers. First, a note about the high-dose vaccine for people over 65. As you know, influenza vaccines don't work as well in people over 65 as they do in younger age groups. That's evident on the left-hand side of this slide with the blue bars showing the percent seroconversion, or fourfold rises in antibody, to the 3 different types, the 2As and the B that were in the trivalent vaccine. With the high titer, the higher dose vaccine, you can improve that serologic response rate in people over 65. It's still not optimal, but you can get up to 50 to 70% responses. The geometric mean titers are on the right. They're also higher, as would be expected. The safety of this vaccine is very similar to the standard dose vaccine. There's slightly higher rates of injection site pain and some erythema, but everything else is about the same. So that it's quite safe. I got this vaccine this last year and had no reaction at all. Some people thought there should be a preference for the high titer or higher dose vaccine, but ACIP has not given a preference. There are 2 factors in that. One is supply. There's not enough of this vaccine for everybody over 65. And they're waiting to see whether there's benefit in terms of reduction of disease, greater reduction of disease, as we would anticipate might occur and should occur with the higher antibody response. But we'll see, and there are studies ongoing to try to determine if that's the case. The big game changer for influenza are data on the impact of vaccinating pregnant women. We've had recommendations for immunizing pregnant women for over 50 years. They're recognized to be a high-risk group. But now we know from several studies and additional ongoing ones that will be completed in the next year that giving influenza vaccine to pregnant women improves birth weight of her offspring. It'll decrease the rates of prematurity and decrease the rates of small for gestational age, and we'll walk through some of those data. Pregnancy alone is a risk factor for increased severity of influenza infections and the need for hospitalizations. The bottom line in this figure shows the rates of hospitalizations by first, second, and third trimester, and the complications increase with as you get further into pregnancy because primarily the hemodynamic load on the woman and the decreased capacity, but also there are immunological effects that influence this. Women with asthma are shown in the top line who have a much higher risk of hospitalizations for severe respiratory disease associated with influenza, just emphasizing the point that all asthmatics should be immunized. The question of safety during pregnancy has had a second detailed review published just a couple of months ago in the American Journal of Obstetrics and Gynecology. And by the way, the College of Obstetrics and Gynecology has really come on board and is now pushing for influenza immunization pretty strongly. So flu vaccine is safe in pregnancy. There's no increased rates of adverse pregnancy outcomes with giving the inactivated vaccine during pregnancy. The landmark study that triggered a lot of the subsequent studies was published in New England Journal in 2008 by a member of our faculty and here at Johns Hopkins in Bangladesh, where they gave some mothers pneumococcal polysaccharide vaccine labeled as a control here, and others during pregnancy got influenza vaccine, and then looked at the offspring and monitored the respiratory illnesses. And you note this slide shows the rates of clinical illness associated with influenza in the respiratory tract. And by vaccinating the mothers, there was a substantial reduction in the rate of influenza disease in children in the first 6 months of life. It was fairly dramatic. The mechanism is probably twofold. This shows the antibody response to the vaccine in the mothers on the left, and then the antibody in their infants on the right. And you can see those antibody titers decline over the first 6 months of life. But also by protecting the mother against disease. The mother is a source of transmission to the infant. So it's passive antibody from the mother, and just protecting the mother helps protect the infant in the first 6 months of life. There have been 3 subsequent studies that have verified these results, all in the United States now, in different populations, showing 41 to 91% reduction in significant influenza-associated respiratory disease, including hospitalizations, almost a 50% reduction in hospitalizations associated with flu in infants. And there are other studies now in place that preliminary data suggests they will be validating this as well. So you protect the infant by vaccinating the mother. But it goes beyond that, and there's a very nice review written by Mark Steinhoff and Saad Omer, 2 former members of our faculty, in the American in the American Journal of Obstetrics and Gynecology just a little over a month ago. They looked back at the birth weights of infants born to the women who had received either of those 2 vaccines in the Bangladesh study. And women who delivered before influenza season began, before January 31st, there was no difference, no measurable difference in the birth weight of those infants based upon what vaccine the mothers received. On the right-hand side, though, is that there was over a 200-gram difference in birth weight, an improvement in birth weight in infants whose mothers had received influenza vaccine. In addition, there was a reduction in the small for gestational age births in that same population over those births that occurred during the influenza season on the right-hand side. fact, the relative risk was 0.58, a 42% reduction in small for gestational age. They also looked at prematurity. The first analysis on the left-hand side, which is a little hard to read, but you can see that when they analyze it by the season of birth, the traditional influenza season in Bangladesh was October through May, there was a 7.9% reduction in the premature births. But when they analyzed it in more detail on the right-hand side, during influenza transmission, which they were able to document, it's about a 16 to 17% reduction in premature births. We have actually known from other studies that influenza during pregnancy can precipitate labor, can increase the risk of prematurity. This is the first intervention study to show a reduction in that incidence of prematurity and a substantial reduction in prematurity. This slide shows the birth weight data again, along with several other studies that have been done subsequently. So the red bar at the top is the improvement in birth weight over 200 grams in the Bangladesh study. Then in the state of Georgia, Saad Omer looked at a large population in the state and was able to demonstrate over a 100-gram improvement in birth weight in infants whose mothers got influenza vaccine and delivered during the influenza season. Two other studies were done, one in Canada, one in the United States. Those are shown in blue. These show the change in birth weight for infants whose mothers had influenza during pregnancy. So in a sense, and they had a reduction in birth weight. They're showing that on this slide as well, just to show the magnitude. 100 grams in one study and almost about 275 grams in the other study. So further data documenting that influenza in pregnancy is a bad actor. It reduces birth weight of the infant. And the mechanism for that is probably multiple, but just making the mother sick, decreased intake, but also activation of cytokines and inflammatory markers which have long been associated with reduction in birth weight. If we look then at SGA from these same studies, this slide shows the relative risk of SGA, a reduction in the intervention trials in the red, and the rate of SGA associated with influenza in the blue line from the Canada study, all very consistent, documenting the impact of influenza on small for gestational age. I will only add that the impact of prematurity in small for gestational age on that infant can carry with it lifelong consequences in terms of decreased IQ, decreased learning ability, decreased growth, and significant complications, especially associated with respiratory illnesses in that first year of life. So this is substantial, and these data and preliminary data from a couple of other studies led the World Health Organization to announce an urgent new program to try to move in all developing countries to provide influenza vaccine to pregnant women throughout the world. This is the first time that's been done for influenza, making a strong recommendation for its use in many other countries of the world. It's going to take some time for this to be adopted, but it's a huge game changer in the field of obstetrics and neonatology. And I expect you will see more data from several other studies in the next couple of years, and more pressure for us to do better than what we're doing. We're above 50%. I think we were at 60% for coverage of pregnant women this last year, but we should be doing better than that, and there still is time for this year. So anybody involved in care of pregnant women should do everything they can to help them get immunized this year. A little bit to say about healthcare providers and influenza vaccine. We know from a number of studies that vaccinating healthcare providers protects those healthcare providers and decreases nosocomial infections from those two studies. There are numerous studies now, but these two randomized controlled trials in nursing homes showed that by vaccinating the healthcare providers, you decrease mortality in those elderly individuals who don't themselves respond as well to the vaccine, but you can protect them by vaccinating everybody around them. Here at Johns Hopkins, we have been implementing a mandatory policy for all healthcare workers, fully going into effect on December 1. But this is happening throughout the country with requirements for immunization of healthcare providers. Controversial over the last decade, but it's happening. And the reason for that are good studies documenting that all of our efforts to get voluntary immunization, recommending, making it easy and so forth, led to improvement from about 40% to 60%, but it was requirements, mandatory influenza immunization that really takes us up into the high 90% in different studies. And with the H1N1, it was a little bit lower, but there was a delay in the availability of that vaccine. So it's happening. All healthcare workers should be immunized against influenza. So what happened this last year? 85.6% of physicians did get flu vaccine, 77.9% of nurses, and 62.8% of others. So this is a big improvement over what it had been, but there's still some room for further improvement here. Now, Ruth Karen spoke in the last hour a bit about pertussis. I'm going to add a little bit to that. You've seen the data showing the increase in pertussis in the country. One of the reasons that we believe this has happened is due to waning immunity in the children. Now, she talked about the short-term protection from vaccinating women during pregnancy or shortly afterward. But a good study published in New England Journal of Medicine just a few months ago showed that the proportion of tests that were being done on children that were positive by PCR for pertussis increased with increasing age and increased with the time since vaccination. More sophisticated study documented that the odds ratio for getting pertussis compared to two different control populations increased with every year since the 5th dose of vaccine. So a 40 to 50% increase in the likelihood of getting pertussis with increasing time since immunization. We're seeing more rapid waning immunity from the acellular pertussis vaccine than we believe occurred from some of the whole cell pertussis vaccines, but there was a lot of variability with those. We believe that that's probably a factor in the increase in pertussis in this country that's gone on in almost all states. Last year there were over 15,000 cases of reported pertussis, which we know there were a lot more than that probably occurred. And I think Ruth showed you the highest incidences in children under 1 who are too young to be protected from the vaccine. This year, 2012, is going to be the record year. Over 32,000 cases of pertussis have occurred in this country. We get 10 to 20 deaths a year from those children. So we do need to implement those policies of trying to vaccinate people who are around young children. These young children, especially the infants, they get pertussis from family members, the mother, the father, siblings, 3/4 of them, and grandparents and others. So we need to be vaccinating them. We've tried this strategy for the last 5 years called cocooning, by vaccinating everybody around them, and it was vaccinating the mothers postpartum. But it was tried in several settings intensively, but it's very difficult to implement and incomplete effectiveness. That's what led to some of the changes in the Tdap policy. There no longer is an age cap. It used to be 65. You can vaccinate those grandparents, everybody, especially those that are going to be around young children. There's no minimal interval between the TD, if they previously received it, and Tdap, so they can get another dose 6 months later. But there's no routine second dose for everybody yet. You heard that it's the pregnant women that are going to be the first group getting that second dose. Why are we doing a lousy job of getting Tdap into adults? We've not done a great job of just getting a tetanus booster into adults. Only a little under 60% overall of the U.S. population 19 to 49 years of age has had a tetanus booster in the last 10 years, slightly lower in those 50 to 64 years of age, only a little around 50%. So we have to figure out strategies to get these boosters in, and that first one should be a Tdap booster. And Ruth covered this, so I'm just going to skip it. The policy that was written a year ago called for giving the dose preferably in the 3rd or late 2nd trimester, 20 weeks of gestation or more. They're looking at this now and may have a change in that, but it will be a dose in every pregnancy. Let me change the subject now to talk in terms of game changers and the fact that we have 2 vaccines to protect against cancers. We've heard a lot about the HPV. I'll say a little bit more about that. But hepatitis B, for prevention of liver cancers. There are several other infections that are known to cause cancers, and I expect that someday you will probably see at least one or more other vaccines to protect against cancer. With hepatitis B, we've had a large impact on the incidence of hepatitis B in this country. It took a while. We struggled a lot with changes in policies to get this implemented, but it's now 30 years since the first hepatitis B vaccines were licensed, and we're now seeing the substantial reduction. The real benefit will still be seen in the future. We had, in the late 1980s, about 5,000 deaths a year from cirrhosis of the liver and or hepatocellular carcinoma. And those changes, those reductions are now being seen. And the future generations will have benefited a great deal from this implementation of this cancer-preventing vaccine. It's taken a long time on a global basis to bring other countries on board. We're up to 180 countries now giving hepatitis B vaccine to infants out of 194, still 14 more to go, but there's been a gradual improvement. There are costs, there are other barriers and so forth, but it's happening, and we will be seeing a global reduction of the severe consequences of hepatitis B in future years. I hope we don't have to wait as long for the impact from prevention of cervical cancer, from implementation of HPV vaccine. There are estimated almost 250,000 deaths a year due to cervical cancer, many others that are treated successfully, early, and a huge burden from all of the screening and biopsies and tests that need to be done for women who have abnormalities. I'm not going to talk about all of those. In the U.S., it was estimated there were about 14,000 who developed cervical cancer a year. We can prevent these with the HPV vaccine. In girls, the vaccine was licensed 6 years ago now, and look at our coverage rates. First dose of HPV by year of age for girls 13 to 17 years of age. Up to 60% for those that are 17 years of age, but the recommended age is 11 to 12 years. So we're only at 40% getting the first dose. The red bars show the rates of the third dose. We're not doing a very good job of implementing a very important cancer-preventing vaccine. And new strategies need to be implemented for getting high rates of coverage with adolescents, especially both adolescent girls, boys. But there's also a catch-up for 19 to 26-year-olds with females. And in 2010, only 21% of 19 to 26-year-olds had received at least one dose. People have dreamed about the cure for cancer. We have cures. The best cure is prevention. And I don't know what the right strategy is, but maybe some of you can help and figure them out and implement them. Money is an issue here. This is an expensive vaccine. I wish it was much less. Getting all vaccines paid for by third-party payers should be a priority under all the healthcare reform that we have. And I don't mind saying that the manufacturers could help us out here. They didn't. I argued they should have charged less. They didn't. They won, but they should have. One of the perceived barriers was that, and part of the reason that some parents still are not giving the vaccines to 11 to 12-year-olds, is that they somehow thought that this would make it so that the girls felt more comfortable having sex earlier. I never believed it. A lot of other people didn't believe it, but now we have real data that show it wasn't true. In a large managed care organization, abbreviated here as an MCO, the average age of diagnosis, the timing of testing first diagnosis for sexually related issues was the same for girls who had received HPV vaccine versus those who didn't. The light gray bars for those who had gotten the vaccine. And similarly, the main age of the first diagnosis of a sexually transmitted related disease was basically the same. So it's not an issue, and people should be encouraged to vaccinate their children early before they get sexually active, which is before the parents know that they're sexually active. We need to be doing this earlier. So males were added a year ago to the recommendation, starting as early as 9, but routine at 11 to 12 with catch-up for 13 to 21, and permissive use for 22 to 26-year-olds. Just getting started, it's 20% or less right now, so there's a long ways to go. But males should be immunized. We're never going to get super high coverage rate in females in the near future, so best control for this disease is vaccinating both males and females, plus the evidence that the HPV-4 vaccine protects against all of the genital, not all, almost all, 90+% prevention of genital warts. And that's why that vaccine is recommended for males. The bivalent is not. Both manufacturers are working on revised formulations that will broaden the coverage. And so right now, 70% of cervical cancers can be prevented, but you can bet that within a few years we'll have broader coverage that I would hope would take us closer to 90% of all of those cancers being prevented. Last point I'd make is that the American College of Physicians has recently come on board recognizing the need for much more active involvement on the part of internists. Pediatricians have been strong promoters of vaccine and great information systems and implementation for a long period of time. All of the subspecialty groups, societies, and there's like 20 of them, have endorsed the need for internists to be actively involved in providing immunizations or assisting with making certain that their patients are immunized. And so the American College of Physicians is publishing the immunization guidelines regularly now and providing a good website and an app for iPhones that it needs to be improved, but it's pretty good right now, that will make it easier to get information for people who are members of the American College of Physicians. With that, I'll leave you with the same conclusion I started with, and that is that vaccines are probably the biggest game changers that we could have in infectious disease. But we have not realized the full potential for these vaccines, and we need to figure out strategies to do a better job than we have. So with that, I'll be happy to entertain questions, John, if any have come in.
They have. So the first question, why doesn't the ACIP recommend Prevnar 13 for adults over the age of 65?
Well, I'm not on that committee. I listen in or go to those meetings, and the debate is there. The person who's asking must be aware of there's one study that shows that there was a better immune response. I think this will be continuing to be looked at, but they didn't feel that the benefit was worth the additional cost, and they wanted to get the broader coverage from the 23-valent vaccine that the 13-valent doesn't get. If one were to do it, the logical thing might have to be to do both. But there's a study going on in Europe, in the Netherlands, which will be out in another year or so, doing a randomized trial of the 13-valent versus no vaccine to look at the potential benefit of the reduction. And I know they're waiting on that study before they're going to make a recommendation just based upon some limited immunogenicity data. So I don't expect anything new for a year. They'd like to see efficacy and improved efficacy.
But let me follow up with that. In the Netherlands, do they vaccinate their children with Prevnar 13?
They were not at the time this study started, so they won't. So that was one of the reasons that they did that. Now, most other European countries are implementing that, and that was part of why they chose that population. So we'll have to see, and I wouldn't say that they haven't started, but they started the study a couple of years ago. It's been going on for a while. So this is an evolving area, and we'll have to see what happens. I know that the manufacturers are starting to advertise the 13-valent for adults, but it's only been recently that it's been approved. So we'll see. And just check in every year, and things will change.
Well, I guess the reason I asked the question is that, you know, if we're going to use policies on the basis of vaccine studies done in another country, where pneumococcal vaccinations have been so effective, can we apply their data here?
That's a very good question. It's one that always comes up. And with widespread 13-valent vaccination, if we can get rid of those serotypes in the adult population, it doesn't make sense to be routinely immunizing with that. And use your money efficiently and get the additional benefit from the 23 valent. I think that's where things stand right now.
And here's a question that actually applies to both human papillomavirus, although it's not part of the question, and the pneumovax. Why don't we advocate for Prevnar 13 in countries where they don't have vaccines?
I didn't bring any of those slides with me, but there is an active and aggressive program to bring the conjugate vaccines to developing countries. There are good data in Africa now. There's a good study, it's now a couple of years out, that showed a 16% reduction in overall mortality in infants in the Gambia. And other studies showing substantial reduction of disease. And so there is an aggressive program to try to make these vaccines available in developing countries. Cost is a barrier. Fortunately, we do have some competition. There's a 10-valent and a 13-valent. I didn't mention, let me just add it here, but I won't be surprised if the manufacturers don't keep adding a few new types. There's some variability around the world of these, and but getting around 13 to 15 or 16 types is going to cover and have a global, vaccine. But the vaccine is coming to other countries. There are half a dozen or maybe a dozen developing countries that are implementing it with assistance from international donor agencies. And actually, it's more than that. I have a slide that shows that it's just getting started. You can't pretend that it's being widely used. But this vaccine's expensive. We need lower cost means of manufacturing it. Those efforts are underway with some developing country manufacturers. Resources are limited, and they need external support to make this happen.
So here's another question. Are there any contraindications to the human papillomavirus, the 4-valent one?
Well, allergic reactions to a previous dose is the most important one, serious allergic reactions, or to some component of the vaccine. However, there's trace amount of some yeast protein left over from the manufacturer. And I don't remember any other true contraindications to the vaccine. It's an inactivated vaccine. It's a safe vaccine. Now, pregnancy, I think the package label says it's a contraindication. There's a registry that's been set up, and so far, the women who were unknowingly pregnant at the time I got a dose, there's no difference in the outcomes of those pregnancies as compared to what would be expected in the general population. But pregnancy is a contraindication.
And then with regard to the human papillomavirus, there has been sort of an urge to vaccinate gay men up to the age of 27. And then the question of why do you stop at 27? Like, just because the FDA trial stopped at 27.
That's correct.
Do you think that gay men should get this vaccine?
Well, one of the things that they looked at, and I don't have the data with me, but gay men who have been sexually active for a number of years have relatively high rates of having acquired the HPV types that are in the vaccine, and there's declining benefit with increasing age and increasing number of sexual partners and so forth. So the focus should be on, getting this vaccine in early. But you're right, the upper limits of age for many of these vaccines, HPV especially, is the upper limits of age in which the people were studied. And so there are data now for women who are over 26 years of age, but there's still not an endorsement for use, in large part because the risk of acquiring the disease is much lower. But certainly, if you have a sexually active gay man who's in his mid-20s and wants to be protected, I see no reason not to give it. There's no evidence of any safety issue here.
Okay. And a topic that we discussed briefly last year, measles and mumps.
Oh, measles
Those
is
have come
still
up
around.
this year. Yes.
Yeah, measles still pops up. In fact, last year was even bigger than 2010 due to importations. We do have a problem with people refusing vaccines, and there's a little small increase in that in a number of populations for beliefs that they shouldn't have. The vaccine doesn't cause autism, of course. And but we have some people excluding their children, then they travel. And there's lots of measles yet in the rest of the world, including in Europe. And so we get importations and then small outbreaks of disease. And the same thing, mumps, 2006, and then in 2010 we had another blip, mostly in college-age people, and we still have some circulating mumps, especially in the Northeast. So be aware of that, and be on the lookout and suspicious if you get the classic, clinical findings. There is some waning immunity. There is definitely waning immunity following mumps. And in fact, now there's some data about there's some waning immunity after even the second dose. CDC is experimenting with some outbreaks with giving a third dose during outbreaks, but no recommendation for a third dose at this time.
Okay, let me ask a couple of questions that I think may have been covered by Ruth a bit. Influenza vaccine. Now that's come under scrutiny by this study that Mike Osterholm did and whatnot. But now there are several different variants of the vaccine. For somebody like you or me, which of the various influenza vaccines would make the most sense?
Well, let me share some data, and I didn't bring the slides, but there's been a couple of reviews looking at children and then adults with the live versus the inactivated. And the data from the pediatric studies, I'm pretty convinced. The well-controlled randomized trials do show that the live attenuated vaccine had somewhat greater efficacy than the inactivated vaccines in very young children. Those are relatively naive, not entirely. They haven't had many influenza infections. There are also data in adults, and I can't reiterate all of the studies, they're more limited, that suggest that the inactivated vaccine provides somewhat better protection than the live vaccine. The data are not definitive yet, and I think we need more studies. There is some rationale or plausibility, for this. As adults, people have been infected many more times. They're further primed. They may not get as good of a take from the intranasally administered live attenuated vaccine. There is no preference for either in the otherwise healthy age population that can get either one of them, age 2 and above for the live vaccine, except until you get to be 65 years of age, and then you don't have a approval, or 60 years of age. Which one is it? 60 or 65 for the live attenuated is an upper age limit, and so then it's only
It's
the
49,
inactivated.
I think.
Is it 49? You are right. Thank you for that.
Yeah.
That's correct. So there's an upper age limit for the live attenuated.
Only because they did the studies in people
That's
up
correct.
to 49.
But I think that, then you just give the inactivated vaccine. I would do it in accordance with the guidelines for right now.
How about the double dose?
The higher titer vaccine, I showed the data on the increased immunogenicity. It's the vaccine I made sure that I got this year, as I'm eligible now. And I would. I mean, come on, you get a higher antibody response, and we already know that the routine vaccine is a little bit less effective. Why not get the higher titer vaccine if you're trying to protect yourself? So.
And is the final question, is the cell culture vaccine, now it's approved by the FDA,
Yes,
is
that's
it
right.
available?
Not yet, but it will be available next year, but not in a full supply by that manufacturer. There may be even a second manufacturer approved for cell culture method. That's a big breakthrough, getting us away from the egg-based production.
In terms of speed.
In terms of speed, and it may allow them to be quicker to make changes and so forth. So we will have, I should have mentioned that, we will have a cell-based vaccine available next year. And again, the exact amounts aren't clear. My expectation would be that the vaccine would probably be about the same in terms of its effectiveness as the others, because it'll have the same amount of antigen and everything. It's just going to be easier for the manufacturer and easier to make some changes. But other companies are working on cell-based vaccines as well. We may see another one, and there's a third company that's working on them.
So it's mainly the speed of production for using cell culture instead of egg-based culture. That's the big
It's
breakthrough
speed,
here.
and also you got to understand how many, you need an egg for every dose practically, and so
Yeah.
you got these huge buildings filled with eggs, that you're making the vaccine from. You can do it in a smaller facility with the cell culture based. And you can
Okay.
control it better. Just think about that, trying to grow vaccines in these eggs that come out of chickens, it's not a pure process. You'd rather have it in the cell line and growing it there. So.
Okay. And if you were in the age group with the live virus vaccine, you would recommend that in preference to the...
No, I'm not going to give a preference.
Okay.
I think we'll let people decide. I think I shared my thoughts about that. For pediatrics, there's evidence that the live is somewhat better. Where that age cut point is, we don't really know. We don't have a clear... Either one works well, and both protect. But outside the upper age limit, then you really should get the inactivated vaccine.
Okay. Well, I want to thank you, Dr. Halsey, for the presentation that you gave. I also want to thank Genentech and Cubis for the support for this educational series. Please remember to complete the quiz at the end of the session to secure your CME credits. I'm John Bartlett, and thank you for joining us.